Tonight we're exploring how redlining continues to shape the world around us. For anyone who hasn't been to the exhibit, the short definition of redlining, which you also should read the long definition, is redlining is the systematic disinvestment of some neighborhoods and people in favor of other neighborhoods and people made largely on the basis of race. Urban neighborhoods were redlined on government and private maps, and suburban neighborhoods were greenlined. So those are big important concepts to know. Decades of private discriminatory banking, real estate development, and real estate sales practices directly influenced and defined new federal home loan policies during the Great Depression, so 90 years ago. And from the real estate industry came the idea that race and value were connected. And although unfounded, they promoted that idea of race, and it became a critical risk in home lending, and that's that system we're talking about now. So because of that, federal funds flowed almost entirely to white populations in new post-war suburban communities around here and in other areas across the United States. And they did that through the home mortgage programs of the FHA, the Federal Housing Administration, and the Veterans Administration. Conventional banking products and state funding mirrored these practices. And urban neighborhoods and communities of colors therefore experienced a lack of investment at any level, high rates of loan denial and rejection, and discrimination in lending, moving, and economic development. Being redlined meant that the area was labeled too risky for doing business. Where there was government and private investment in redlining segregated neighborhoods, it often came through urban renewal projects or the development of private industrial sites. And all of that is going to come in to tonight's topic. Greenline neighborhoods, on the other hand, were protected, quote unquote, from risk by restrictive covenants, including those that prohibited certain races from buying homes in a specific area. Suburbs had the protection and proliferation of green spaces and a concerted investment in infrastructure. Redline spaces lacked these investments, and over decades of disinvestment became home to dilapidated housing and crumbling infrastructures, high rates of pollution and toxic brown zones, and as a result, the topic of tonight, community vulnerability and lower life expectancies. So those are some of the modern day legacies of redlining on the built environment, the natural landscape, and the human condition in our areas. Our conversation tonight may point towards actions and a future where the disparities between communities and neighborhoods, some as close as simply across the street from one another, might become more equitable. And luckily, you get to hear from experts on this. Tonight, we have a really great panel for you. Our moderator is Andrew R. Gustafson, the Curator of Interpretation for the Johnson County Museum, and he was the project lead on the Redline exhibit project. He researched for 18 months, during which he read hundreds of books, articles, and original documents and archives across the region and online. He wrote an 85-page research paper that was heavily footnoted and spanned almost 200 years. Almost like a master's thesis, and he worked with the staff to develop the exhibit script. He's given more than 60 guided tours of Redline, and my office is right above the gallery, and he gets applause at the end of almost every one of them, which is hard when you're giving a tour on a really heavy topic. He holds an MA in history from the University of Houston and has nearly 10 years of experience in public history. He serves as the president of the Heritage League of Greater Kansas City, and he continues to research on redlining. Next, right next to me, we have Julie Brewer, who's the Executive Director of the United Community Services of Johnson County. UCS is a nonprofit focused on poverty and health and human service issues impacting Johnson County and its residents. UCS's core work is illuminating needs and solutions through education and advocacy, fostering a framework for collaboration through mobilizing and planning, and prioritizing community investments through targeted resource allocation. UCS recently facilitated a multi-sector community collaboration with area jurisdictions to address the priority of safe, stable, and attainable housing, which has resulted in both a housing study and a toolkit. Julie has 30 years of experience in nonprofit and for-profit sectors and serves on numerous county and by-state advisory boards. Next to Julie, we have Kiana Thomason, who is a lifelong Kansas Citian and has dedicated her career to the improvement of health and wellness across the region, with a special focus on powerful and resilient communities experiencing health injustices and people living in marginalized conditions. She is the president and CEO of the Health Forward Foundation, an independent, purpose-led foundation serving urban, suburban, and rural communities in the Kansas City region. She came to the Health Forward Foundation from Blue Cross and Blue Shield Kansas City, Blue KC, where she served as Vice President of Population Health and Community Health. And before that, she spent 8 years at Swope Health, a federally qualified health center, as Program Manager for Regional Mental Health Court and as Director of Clinical Operations and Behavioral Health. Welcome. Next, we have Megan Foreman, who is the Program Manager of the Johnson County Department of Health and Environment, where she oversees grant programs on chronic disease and community violence prevention. Most recently, she started the department's Community Health Worker Program, which helps residents navigate systems and connect to resources that address the root causes of poor health. Prior to joining the Department of Health and Environment, Megan spent 10 years in the health policy at the state level. She has a bachelor's degree from the University of Denver, and in a few short months will have a master's degree in public administration and policy from American University. And finally, we have Dr. Alex Francisco, the Chief Science Officer for the Kansas City Health Department, who has a PhD from the University of Missouri, Kansas City in experimental health psychology with expertise in health decision-making and pro-social health behaviors. Prior to joining the health department, Dr. Francisco completed a postdoctoral fellowship at the Army Research Institute at Fort Leavenworth, and his current efforts as the Director of Population Health Science at the Kansas City Health Department aim to explain the inequity in small area life expectancy estimates to drive actionable steps towards health equity in Kansas City. In short, we've got a lot of great experts here tonight. I thank you all for being part of this, and let's have a great conversation, shall we?
Awesome, thank you so much, Mary. Well, let's jump right into it. I think we have a pretty good conversation ahead of us, and let's get started, right? So I'd like to start the conversation by talking about what things contribute to health in a community setting. So I think we should start with some definitions for everybody, so we're all on the same page. Julie, can you define for us what social determinants or social indicators of health are and how they impact community health?
Absolutely. And you know, we have a little video in just a moment that will show, but you know, really the short description of that is where you live, work, learn, play, and pray impacts your health. And when we talk about health equity, it means that everyone has a fair and just opportunity to be as healthy as possible. This requires removing obstacles to health, such as poverty, discrimination, and their consequences, including powerlessness and lack of access to good jobs with fair pay, quality education and housing, safe environments, and health care. You know, one of the things that is heartening is over, and Kiana can maybe be more specific on the timing, but at least over the last 5 to 7 years, do you feel that health systems have started to think more intentionally about the social determinants, or I believe sometimes we say the social influencers of health, and think about that embedded in their work and seeing all of us, not just our genetics or our access to health care. And this is even something that's put out, that's another easy descriptive to think about, really, that more than 50% of our health is really determined by our physical environment. So do I have access, am I in a food desert? Do I have access to, say, sidewalks, parks? Can I walk to places because of that, or safety issues that I cannot walk to places, and how does that affect my health? And then socioeconomic factors. You know, we use the term roots and bootstraps. Sometimes we don't think about how we got our roots or our bootstraps, or who helps us with those roots and bootstraps. But that's, a lot of that is your access to education, job, just social emotional supports in your life. All of those play a huge factor in our health. I mean, just recently, they have come out starting to think about children doing mental health screenings as young as 8 years old, thinking about the impact of trauma or adverse childhood experiences and how that really shapes and affects your ability, influences your health.
Thanks, Julie, that's great. So, Megan, can you help us define what public health is and why the history of redlining is important in the work of public health?
Yeah, certainly. If you go, there's the slide. I think kind of as I talk, if you want to sort of explore that really hairy slide for a couple of minutes, that'll help. But public health is really the science of protecting and improving the health of people and communities, which is a totally different approach than the approach that your physician might take if you go into the doctor's office and they treat you for an illness or an injury that has already occurred. So the public health approach is is really about going upstream and identifying the root causes that contribute to the poor health outcomes that we see. So we also really have a duty to take broad action to prevent some of those poor health outcomes in the first place. And so, how do we do this? We really look at the systems and the impact that those systems have on the whole community's health. So you'll see on this slide, it talks about institutional inequities and social inequities and kind of walks you through how that ultimately can lead to a decrease in life expectancy, which is something that Alex is going to talk a little bit more about. But, I think in Johnson County, we see, relative to our neighbors, much better health outcomes than we do in those areas that were redlined. And that's really because the community has invested in education, in infrastructure like parks and sidewalks, safety. We have a high cost of living, which often means that many of the people who live here have jobs that pay both living wages and provide health insurance, which is a major driver of access to healthcare. And I just also want to say, does that mean that Johnson County doesn't have any problems or any disparities? Absolutely not. But there is a stark difference between Johnson County and these areas that were designed by policy to have poor health outcomes.
So here's a question for the whole panel to think about. We're going to go around sort of each person to answer. How does the history of redlining in particular shape social determinants or indicators of health and your particular work in public health? So for Kiana, how were or are social indicators of health for a community shaped by the history of redlining or community disinvestment? And I'm thinking particularly about areas east of Truce. So on the map here on the right side of that red line, the Truce divide, right? Could you speak to that a little bit?
Well, it's a huge topic to dissect because it's so layered and complex. So I'll do my best, and thankful to Mary for providing some overarching context. So in a nutshell, unhidden policies and laws explicitly segregated every metropolitan area in the U.S., every single one. Racially explicit policies and laws at federal, state, and local levels predetermined and defined where white people could live and where black people could live, or would live. And they did that through three principal tactics. Mary covered these three. One, covenants, neighborhood covenants, that basically said black people cannot live here. Two, through providing mortgages to black people, or providing, this is the third, subprime mortgages to black people, which they'd be crazy if they took, right? And so these policies, in effect, barred many people of color, black people specifically, from wealth-building opportunities. In fact, 1.2 million veterans, black veterans of World War II, who were told when they got home that they would get the GI Bill for education and for housing specifically, received the benefit on paper, but could not effectively use the benefit because of the systematic barring of their access to it at the practice level, where the rubber meets the road. They couldn't use it. And when you think about how wealth is accumulated in the United States, home ownership has always been and remains one of the principal wealth-building strategies, right? So when we think about that systematic barring and all the other elements of redlining that are in place, but this one specifically created this, what people call the wealth gap, the white and black wealth gap, which is 10 times greater in white families than it is for black families. Of course, there are many other identities in the middle, but we talk about things as black and white because that is the U.S. system, and that is the construct in which it segregated through policies and laws. extract resources from the communities because white people fled to the suburbs, so white flight, maybe you may have heard that term. Not wanting the whole, NIMBY, not in my backyard, don't want black people living next to me, so white folks fled. And you just experience extraction of quality jobs, extraction of safe streets, extraction of investment in neighborhoods, good quality grocery stores, schools. So extraction. And those resources were then redistributed to the suburbs. And so the wealth gap, which allows people to socially and economically advance in their life, was designed, by design, on purpose, right, through decisions. And so when we think about contemporary implications, redlining is very much alive and well. While it may be barred from a legal standpoint, the effects of it through the wealth gap have modern day implications. And so that's essentially what we talk about when we think about the social influences of health, quality jobs, fair pay, affordable homes, transportation. And so this chasm, if you will, affects many layers of social economics, if you will. So that's the best I can do in a nutshell.
That's great. And we're going to come back to that idea of creating that chasm and what that looks like today a little bit when we get back to Alex. Megan, so Johnson County was an area in which many residents received direct investment through the FHA and the VA mortgage programs for new housing. And to pick up on something that Kiana said, it didn't really matter if you had saved up money for years and years and were ready to build your own home in the suburbs, or if you were able to access FHA funding for the first time and you could stop renting and buy your own house through the FHA, or if you were really racist and didn't want to live in an integrated neighborhood, right? All those things are built in together in that system through the FHA. You can see this in the exhibit downstairs. We have pullouts from the FHA guide talking about you must have recorded restrictive covenants on those properties. So to get back to my question for you, Megan, this area had a lot of investment through those mortgage programs. And the county and its residents have also benefited from investments in infrastructure, things like sewers and highways and schools. So what can social determinants or indicators of health look like for a place that experienced that direct investment at a government and private level, places like Johnson County? What do we see happening here before we then get into what it looks like in disinvested areas?
Sure, and I think at the very baseline, we look at life expectancy. So in Johnson County, the life expectancy is 81.4 years compared to our neighbors in Wyandotte County. And they do some health rankings. Yearly, they come out, I don't know, some of you may have heard, Johnson County typically ranks first as the healthiest county in Kansas of 105 there in Kansas. And Wyandotte County typically ranks last or very close to the bottom of that list. Geographically, as many of you know, we're neighbors. And so I don't think it's too far of a leap to think about how community design really does impact that bottom line of life expectancy. Johnson County is 81.4 years, Wyandotte County is 74.7 years. And I don't want to steal your thunder, but it looks even worse across the state line. And I think a lot of that really is due to this map right here that we're looking at. Johnson County was built as a bedroom community. And so the people who moved here and the governments that then took their tasks from the citizens invested in really good public schools, invested in green spaces, parks, trails, other things that the community has said over the years that they want. And we continue to enjoy that today, but you can see the generational impacts then of the disinvestment or the investment in some of these amenities.
So, Julie, can you help us understand how things like housing and family budgeting and things like that are impacted by where one lives? Thinking about, in turn, how that impacts community health.
So if we could go back actually to the systems slide for just a moment, because I kind of want to center there as we think about the social influencers or determinants of health and why housing bubbles up. And I think Kiana and Megan have done a great job on really focusing on why housing, as for most of us being that single most significant builder of wealth or big investment over time. But I want to center on systems for just a minute, because sometimes when we talk about systems or we talk about policy, we think it's something out there, something other. And I think we need to center on the fact that systems are us. People make up the systems. People create the policy. You're either creating the policy, being impacted by the policy, or enabling the policy or the system. So I think we need to center on that as we think about what our individual commitment or individual skin in the game looks like when we talk about these issues. So they don't sit up here, but they sit with us as individuals. So when we think of institutional inequities and social inequities and living conditions, so we're going to focus on that living conditions because they're all interconnected. The work that United Community Services has had the privilege to do in collaboration with our jurisdictions in the county around addressing, we received a health foundation, Kansas Health Foundation grant a number of years ago to focus on healthy community initiatives. And we were tasked with putting together a multi-sector committee and to go out and do community listening on top of our research. And we identified the priority health issue as housing, because it was impacting people across all ages and stages of their life and acutely impacting some of our most vulnerable populations. And what does that look like? So now we can go forward to a couple of the slides. We just pulled a couple slides just to kind of give you a snapshot. So the most recent data that we have, and that I believe is really 2020 dollars, in what does it cost monthly for a one-parent household with 2 children to live in Johnson County. And so that different segmented, colorful graph shows you that when you roll up, it's almost $6,800 a month for a 3-member household. So that would be a single, single-head household with 2 children to have a sustainable living in our community where you're not making difficult choices either around your health care or your child care or your nutrition. I will tell you, when the federal government went into sequestration back in 2018, subsequent to that, they did a national data and they said, what was the first thing, what was the number one thing you make sure you utilize your resources for? It was your housing. What was the first thing that went out the door? It was your health care. So it's a direct correlation of health and housing. So what does that look like if I earn $15 an hour in this community? You will have heard for years, because our federal minimum wage is $7.25 an hour. And I always find it ironic that the same institution that measures poverty year to year knows, using a 1960 formula that's basically based on your grocery costs, not on your child care or other costs. So I'm measuring poverty, and I'm the same entity that's establishing the minimum wage that what I want to say, ideally is supposed to allow me to keep body and self together. We know today that if you're earning minimum wage, you are guaranteed to be living in poverty. And that's based on if you're working full-time, full year, and minimum wage jobs are not 2,080 hours a year, right? So there's been a push to move that to $15 an hour, but even at $15 an hour, you're meeting only 30% of what it would cost to live in this county. If you're at 100% of poverty, which is a little around almost 22,000 for a household of 3 in today's dollars. You're at 27%, only making 27% of what it costs here. And then if you are working that $7.25 an hour job, and keep in mind, the state of Kansas pins its minimum wage to the federal minimum wage and has doubled down in one of the employment preemption laws passed in the last decade, and says that a community cannot set a minimum wage other than what the state minimum wage is. In other words, we know in different parts of the state it costs, right, different. What it costs to live maybe in Johnson County versus maybe what it costs to live in Garden City may be different, but I cannot, as a jurisdiction, say I recognize that, therefore I'm going to lift the ceiling of the minimum wage. We're tied to the state by statute, and then the state is tied to the federal by statute. Then if we want to go to the next slide. So what does that look like in Johnson County? So this is a part of a community housing study. And in that, we looked at, one of the things we looked at is if you were earning around that $15 an hour, which would be a little around $1,250 a month, do we have jobs that pay that in our community? Yes, we do. So the heat map shows you the darker the areas is the higher the concentration of those jobs. Oftentimes when we speak to folks, they will say, you know what, those minimum jobs in food service or retail, those are high school. That's my kids work those jobs. I'm okay if they earn minimum wage. Well, the age data shows you that more than 50% of folks who are employed in those positions are 30 years and older. So it's not just the high school kids working those jobs. It's 50% of those jobs are populated by people who are going to be the primary household income for their family. And we use this because as we talk about housing and we talk about another barrier, public transportation, so you think about the three-legged stool, wouldn't it be awesome if you're thoughtful of where your modest paying jobs are, if you're intentional in what your housing and transportation solutions could look like? Oh, and it would lend itself well because it's along a lot of your major transportation corridors. So then we ask ourselves, who can afford to live here? And we look at some recent data that shows us that just in the last 5 years, our costs, our average home sale cost has increased by more than 37%. So we have to ask ourselves, where has income gone? And it has not. And we're showing jobs, many of which, do you remember during the height of the pandemic, a lot of love for what we call essential workers? Folks who we felt really helped give us a sense of normalcy. And I will tell you early on, when we were doing some of our data and work in this area, we were doing some data with school districts, with cities, and with employers. And on average, 30% of their employee base cannot live in the communities to where their jobs are. And it's fun if you're choosing by choice, right, to maybe live somewhere else. We're not talking about someone by choice who decides they want to be a 40, 50-minute commute from their job. We're talking about when I don't have a choice, and what does that look like? And how does that ultimately impact the vitality of our community when the people who care for us, the people who educate us, the people who protect us, cannot live in our communities?
So I think that's a really good grounding in what it can look like for housing, right? The importance of housing and affordable housing in areas. But there's also a biological ramification, right? That I want to go back to something Kiana touched on, and actually, Alex, we're going to go to you. In your role, you get to see some of those biological ramifications of living in inequitable conditions, things that can contribute to one's quality, but also one's quantity of life. And so, can you explain that a little bit and talk about the platform that you all are working on?
Yeah, absolutely. So, just to touch on, what it's like to live in an environment where every day you have a certain higher threshold of general stress, I think is really important to emphasize, because it's easy to lose sight of that if you don't have that in your own life. Think about income in particular, just going off of what we've previously talked about. Just the fact that you don't know what you're going to be able to afford later that day, tomorrow, can really add a layer of stress that causes you to behave differently. And on top of that, it becomes biological insofar as it causes you to have different hormonal profiles, which then causes you to behave differently in change. And so these are the types of issues that really drive lower life expectancy in a lot of our zones. And so in Kansas City, we have an entire range of life expectancy that goes from 62.2 years to 88.1 years. And the ability to determine that is an analysis that drops us down from zip code level data to census tract level data. And when we examine these types of relationships at the census tract level, you can really start to see just how close in geography some of these locations are, where we have such large differences. What we really want to emphasize as we go through some of the information around this topic is that these are going to be risk factors and behaviors that you may consider a personal decision. You may consider this something that somebody is choosing to engage in, and as you'll see once we get to the maps, that's not the case. There are environmental constraints on an individual's ability to engage in healthy behaviors that are well outside of their control. And if that weren't the truth, then we wouldn't have concentrations in certain areas of the city. If this was just a decision that folks were engaging in, we would have a much more even or random distribution throughout the city of these types of behaviors. So we can go to the next slide. Yeah, so what I really wanted to do is highlight a tool that one of my team members is here, Nicole, say hi. We put together something that we've been calling the Kansas City Health Explorer, and it's a series of maps based on an analysis that we conducted to explain that range. Like I said before, the range in life expectancy across the city is 62.2 to 88.1 years, but the question is really why? What is driving that beyond the answers that we know to be true, which are systematic oppression and structural disinvestment in certain areas. But the question is, what is the health reason? And for me, working at the health department, I wanted something that was within my control to at least advise that we can actually address. You know, I can't give anybody any more money, so what are the things that we can actually address as a health department, or behaviors that we can encourage, or things that we can highlight to the city to say, you know, there's a real issue here that we need to address as a city in response to the systematic disinvestment over literally decades, and even centuries in some cases. So we utilize this data set called the Behavioral Risk Factor Surveillance Study that comes out of the CDC. It highlights a bunch of different risk behaviors and certain things like cancer screenings. I'll have the whole list up here in a second. But what I wanted to do was try to use those data to explain that difference top to bottom. What is driving the differences in life expectancy? The model that we ended up putting together was capable of explaining half of the difference in life expectancy top to bottom. And if there are any stats nerds out there, you will understand that's a huge amount of variation in its ability to explain that. A lot of the stuff that I did for my dissertation was explaining like 10%, 7%, and I was like, oh, I did a great job. And this model is capable of explaining half of the variance in life expectancy. So these are the total variables that were put into this model. So any of these could have been determined to be the most important. And there's some really, really important things up there. Rates of depression, a lot of stuff about dental screenings, a lot of screening behaviors. I hoped would have been more impactful, but they didn't end up being very impactful because of some of the things that were just extremely important for overall health. And so these were the possible variables that might have risen to the top. And if we want to go, actually I think it's on the last slide. but one back actually, sorry. There ended up being 6 specific variables that were capable of explaining those differences in life expectancy across the city. And so the number one most important thing was a resident's ability to sleep for more than 7 hours per night. And that one, I was a little, I had mixed feelings about it, because that's a really difficult thing to address. And on top of that, I would imagine that most of the folks in this room consider sleep an individual behavior. It's really, every piece of literature that you read when you're talking about sleep is suggesting sleep hygiene, don't use your phone before you go to bed. I have seen very few, and the ones that I found because I was looking for them very specifically, very few articles that actually talk about what the structural and environmental influences on someone's ability to go to sleep in a timely basis are. So the second most important piece of information was the percentage of folks who've had a stroke, asthma, smoking, exercise in their leisure time over the past 30 days. That one was kind of a complicated question in the survey, but most specifically it just said, have you exercised once in your leisure time over the last 30 days? Yes or no? And there are areas of the city where that wasn't possible for up to well over half of the residents in that census tract. And as you'll see, we try to explain that because after sleep, that's probably the other one that most folks would consider a personal decision. You're just not exercising. You should stop being so lazy and get out and exercise. But as you'll see, that's not the case. And then finally, rates of diabetes, which are intimately related to chronic stress and food excess, as we can talk about. So I think now we got to go a couple slides.
Yeah, go to this slide just for a second, Mary, so everybody can kind of analyze and get this stuck in your brain and see on the right side of that red line, that truce divide we've talked about, right? Sort of the historical line of segregation in Kansas City. It was reinforced after school districts in 1954. They were supposed to integrate. Many school districts around the nation didn't choose to do that. They changed their boundaries and became de facto segregation. So segregation in practice rather than de jure segregation by law. They changed their boundaries. And in Kansas City, the school district chose to use Troost Avenue as the boundary of school districts. And that made some major changes. For example, Troost Elementary School in 1955 had a 3.3% black student population. But after it changed its boundaries by 1965, it had a 93.3% black student population. And there's a long list in a book by Kevin Fox Gotham called Race, Real Estate, and Uneven Development that goes through a dozen schools and shows the population changes in that way. So I think it's really important to understand that context, how that is the racial dividing line because of those other intentional decisions. And so get the red and yellow neighborhoods on the right of that stuck in your mind. And let's go ahead for Alex for the next series of maps.
So this map is the primary driver for the Kansas City Health Explorer that we developed, and it's live now, so you can find it at kcmo.gov/Health Explorer. This is the distribution of life expectancy estimates across the city by census tract. And I just want to point out one interesting thing about life expectancy in and of itself. We've been talking about redlining as a consequence of mortgages and people trying to issue home loans. Life expectancy in and of itself as a calculation only exists because insurance companies wanted to make sure that they were aware of how long somebody's going to live. The whole calculation was developed in its current iteration, at least founded in insurance. So I just found that ironic. But this is the distribution of life expectancy throughout the city. And interestingly enough, this one shows the truth divide the least. Every other map after this will show that line. You won't have to ask, you won't even have to remember the map. You'll see where they are on every single one. We have, I would imagine that some of you can even guess where some of these neighborhoods are. The lighter colors are indicating higher life expectancies. The darker colors are indicating lower life expectancies. This in particular is what drives the outcome for all the other analyses. So all these other maps are just to illustrate the factors that we just mentioned, which are driving the differences in life expectancy on this map here. This is the most stark difference that we can find throughout the city, and And this is across the Truce Divide here on the left, again taken right from the Health Explorer. And on the right, what we've done actually is just take all of the tracks right along Truce to left and right. And this tract here, I know you won't be able to see the base map, is right at UMKC. So on the left there is UMKC. You might be able to just make out Rockhurst University there on the right. And that tract has a life expectancy estimate of 86.3, just across the street. So we're not talking miles anymore, we're talking literally hundreds of feet. The life expectancy is 70.2 years, so 16-year decrease just across the street. Overall, the tracts, overall left and right of Truce, it's 82 years and 72 years. So like I mentioned, you really won't need to have that map in mind in order to see the Truce Divide throughout the city. On the left here is the concentration of folks who are getting fewer than 7 hours of sleep per night, and on the right is going to be the stroke map. I want to focus here on some of the sleep-related variables because this is one of the more complicated ones, and I'd be happy to hear suggestions from folks. We talked a little bit about some of the reasons why this might be the case. It's so complicated that it essentially warrants the same type of analysis with sleep as the outcome instead of using life expectancy as the outcome. But you can see one of the things that I always like to point out is that something right in the middle of the darkest color right there is a highway. And something as straightforward as just the highway noise keeping folks up at night, ambulances going up and down there, police cars running up and down that highway, just general street noise is going to cause an issue. One of the ones that isn't so kind to the city to point out is that we installed a lot of really bright lights in these areas to reduce crime. And I have a sinking suspicion that it might actually be causing difficulty in folks falling asleep. A lot of these are now LED lights, which are super bright. And so some of the things that we have to keep in mind as we try to address some of these issues is what the downstream effects end up being. A lot of the folks in the zones work more than one job, so the average number of jobs on east of Truce is much higher than west of Truce. And so if you're thinking about waking up really early, one of my other colleagues takes the bus to work or bikes to work every day, and he talks about the inconsistency of the bus routes. And so one of the things that happens that we have direct evidence of, somebody has to be at work at 8, but their bus leaves at about 7:15. It only comes on time or at all, maybe once or twice a week. So instead they go to the 5:30 bus. And right then and there, you've already limited yourself to less than 7 hours of sleep, most certainly by the time you go to bed to get up that early. So the map that I think I want to talk about the most is the asthma map, because it has the most directly addressable features to my mind, because this one was shocking. Of all the maps, I knew what they were going to look like before they came out. The asthma map was really surprising to me, so that's the map here on the left. And all the things that are illustrated up there in yellow, obviously, is the asthma rates. The bubbles are indicative of facilities that are generating emissions. And in particular, the red bubbles have generated fees because of their excess emissions. And the fact that that overlays so cleanly with the asthma rates throughout the city was, I want to say it was a surprise, but it really wasn't. We knew that these were causing issues, but there's such a power to seeing that laid out on a map. You cannot deny the structural disinvestment of these areas. Prior to doing this type of work, maps, I didn't really care for maps. They don't have a lot of numbers on them. They don't really tell you all that much. But seeing something like this, I think, really hammers home that we are the cause of this. We chose to place these facilities in these areas. We chose to specifically segregate schools across the Truce Divide and then actively disinvest in the areas east of Truce, and it's still having ramifications. The asthma rate is the third leading reason why these areas have lower life expectancies, and it's so addressable. It's so small that we could easily do something about it, and we don't.
mention something really quickly on asthma? Asthma oftentimes is the leading reason why children miss school. And at state level, our schools are accredited in large part by their attendance numbers. And when you look at the Kansas City, Missouri School District, which you all probably know just recently regained accreditation after years of not having it, their number one reason for kids missing school is asthma, as well as them being transient, not being housed. And the asthma is coming from the environmental situation in the kids' home. And so strong correlation between asthma and health, which has macro level impacts on a kid's ability to learn in a quality accredited environment. So these are systematic policies, like it's a policy issue, that is disproportionately affecting Black and brown children. In the Kansas City School District, that's not affecting other kids, other places, because of the attendance linked to accreditation and the housing and health issues in the urban core because of this investment.
And the last one that I like to point out is physical activity. And this one is going to be a lot harder to see the relationship because of the sidewalk health that we've layered on top of it. So go to kcmo.gov/health explorer, and you can find it yourself. And you can zoom in to as low a level as you want. You can all the estimates. You can click on the sidewalks, and it'll tell you its percentage of health that we derived from our friends over at Public Works. Underneath that map, it lines up so cleanly with physical activity that it's that one again. Not a huge believer in maps prior to this. That one was astounding. And it's so small that you can see, if you see the little red dots on actually the west side, which we haven't talked all that much about. If you look at the west side, there's one little tract that has a really low physical activity, and it lines up perfectly with where the sidewalks have been disinvested. And that is a policy issue. These areas were chosen to have their sidewalks either repaired or not repaired. I won't get too much into it, but I run a lot. And I can feel the differences as I run through the city, north to south and east to west, in the investment level. And the sidewalks are one of the clearest examples of that. I can literally see on my feet where I have to pay more attention because I know that there are going to be poor sidewalks coming up because they've been routinely disinvested over a long period of time. So those are the 6 variables that we were capable of determining. One of the things that I cannot reiterate enough is that the reason why these are popping up in specific areas they are because of the demographics. We wanted to focus on the specific health behaviors that we can address as a health department, but by utilizing the analysis at the level of the census tract, the census tracts are developed by the Census Bureau, and they are actually somewhat chosen to be demographically representative of the area. And so they'll draw them to contain folks who are of similar demographics. They're not doing that for nefarious purposes by any means. That's just what the Census Bureau does. But as a result, you can actually do analyses that illustrate the effects without directly, if I were to include race and ethnicity in this analysis, it would hide everything else. Nothing else would be important. And so by using it at the census tract level, we're able to see, okay, so race and income are driving this, but what are the downstream effects? What are the consequences of disinvestment in these areas in terms of health and then eventually life expectancy?
Those maps are remarkable. I am a believer in maps. Maps are very simple. And I joke about that in the museum all the time. But I will say, just looking at the one for diabetes and some of the others, and thinking downstairs in the exhibit how we talk about the lack of grocery stores with fresh fruits and vegetables, and the types of restaurants that are in areas, and it correlates to so easily on that map to be able to see.
Real quick.
Yeah, absolutely. Go ahead.
What I love about Alice's research, and the research of both the health departments in Johnson County and Kansas City, is that the data allows us to myth bust, and it allows us to begin to shift narratives about what has happened and about what is happening. When they both shared, or as they both shared about the life expectancy differences and disparities based on redlining history and where people of color live, if you look upstream to the sleep and the diabetes and the stroke, if we really wanted to label what was happening on death certificates, it's racism. It's not just diabetes. It's not just stroke. It's racism. And it's important that we sit with that and that we name things and call things as they are, because it allows us to shake ourselves loose from this is just the way it is, and really begin to own our power and our duty, which Julie called us higher to do. That we get to choose, you get to choose. So every time you go to your school board election, you're choosing. Every time you go to the ballot box, you're choosing how this shakes out. I just want to be clear, name it, use data to shift power in areas, because everyone is not okay with just the moral good of this, right? Some people just have to understand the data. So I think it's a powerful tool to shift the narratives and to really name and center what the real problem is that we're talking about.
Yeah, thank you. I'm going to switch things up a little bit, just so Mary's aware, switching the slides. We're at about 55 minutes, and so I want to be aware of time. I think we'll go over by a few minutes, and then allow for some question and answer for any folks who like to stay for that. So maybe briefly, well, I was going to go to Julie, but the slide's up for Megan. Can you just talk about the Johnson County piece for that? That there are areas that are struggling here too. What does that look like? And then we'll go to Julie. So maybe 2 minutes or so for these answers.
Sure. Yes, there are parts of Johnson County that struggle too, but I think I wanted to turn this narrative a bit on its head from the way that we usually talk about it and ask, what did all of this sort of great neighborhoods, great exclusivity get us? I mean, we've done some surveys of Johnson County residents, quite a few of them over time, and there was one that kind of stuck out, and the question was, do you know your neighbors? And the response, and I in no way think that this is all of Johnson County, but the response was, I like it that I can go in my garage, shut my garage door, and I don't have to talk to anybody else. So that is a privilege and a burden, right? I mean, there is an economic level that you have to be at that you don't ever have to interact with anyone that you're around. But, I would say we have very high rates of depression, anxiety. 1 in 4 people nationally say they have no one that they can talk to about a personal problem. No one. I mean, I saw several people walk in here as couples, friends, just groups of people who are interested in the same kind of thing. That's depressing, right? To think about how isolated people are. In Johnson County, there's one suicide every 4 days, and more people attend. So I would put out there that I'm not sure we're better off having all of these amenities necessarily if we forget that we also live in community with other people. So I just real quickly kind of want to point out the signs over there. We've started, it's actually just sort of a group of partners and residents, citizens who want to think more about community connectedness and think about how we show up for one another, be that at the ballot box and by voting and being conscious of what history is doing, the effects that it is having today on our population, or just stepping up for somebody who needs some extra support. So their yard signs, they're kind of a fun counter to maybe some of the political yard signs that you may or may not like to see when you drive around. But they say we respect each other, we care about each other, we look out for each other, and they're free. Start a movement. But yeah, connection is really this sense of feeling like you're part of something that's larger than yourself. And they don't have to be long, just meaningful and authentic.
So actually, I want to ask the next question to Kiana, so we'll leave it on the slide around for now, and then we'll go to Julie. Kiana, your organization, thinking about togetherness and across organization works across the entire region, right? And so in previously redlined communities and previously greenlined communities, can you talk a bit about regional approaches that you have, responses that work across state, county, municipal lines?
So Health Forward Foundation is a purpose-led foundation. We center health equity as our North Star through racial equity and economic justice. As a part of that, just a few examples for regional work that's going on. We are really working with municipal government around centering racial equity in all policies to ensure that a racial lens is being applied to the discourse and the decisions that are being made at municipal levels. We are supporting some learning and somewhat of a community exchange of practice in Johnson County with the racial equity in cities work that Julie's a part of, as well as the Office of Race and Reconciliation in Kansas City, Missouri. We're also supporting the Regional Housing Partnership, which is addressing the affordable housing crises in our metro area across the region, not only housing units and looking to create more affordable homes and units, but also making sure that there are just policies that apply to not just neighborhoods, but developers who need to ensure that there's appropriate levels of access for lower income individuals to access the housing. We have supported right to counsel. So in Kansas City, 9 times out of 10, anywhere, if you don't have an attorney and you're facing eviction, you're going to lose your housing. And so we have supported in Kansas City to where if you're facing eviction, you are eligible for free counsel. And in 98% of the time, if you have an attorney, you stay housed. And so those are the types of things that we're focusing on, as well as just some overarching work to support asset building, wealth building in communities through home ownership and through a focus on Black and brown talents' access to the health sciences pipeline. So those are some examples of many that we are focused on around racial equity and economic justice as pathways to health equity.
Thank you. Julie, what are some obstacles that your organization, thinking about your housing work and things, the studies, what are some obstacles that your organization faces in seeking to address the disparate health outcomes?
So I'm going to talk about obstacles and opportunities because I'm a positive person. I like to be action-oriented. And first I want to center us in something that's been talked about quite a bit, and Alex really illuminated when he said, you know, some of this data has been hard to measure and hard to discuss because it appears as though these are personal decisions. So I want to get that out of our heads, and I want us to think a moment. There's a difference between the choices we make, that concept, and the choices we have. That's a different concept. We have a tendency to judge each other by our own lived experience or frame of reference. I'll take smoking as an example. I've worked in health and human services for over 30 years, and you feel like that's a really bad personal decision. But now think about what you do to relax. And think about what you have access to that allows you that letdown time. For some folks, smoking is the only affordable thing I can do. I can't go out of my house, it's not safe. I don't have enough time to exercise, the resources to have a hobby or have an activity. This is that one little thing I do for me. I may know it's bad for my health, but it's the choice I have, not the choice I make. You know, I'm limited. So I just want to throw that out there. And some of the obstacles that we encounter when we think about and we engage in this work is sometimes we hear that I wasn't around when discrimination was happening. I'm not a part of discrimination. Well, just because certain things are no longer legal, so I have stopped doing that thing that's legal, isn't the same because there was an intentional actions that created the ecosystem we have today, how are we being intentional in creating the ecosystem we want tomorrow? It's not enough not to do that anymore. Home ownership for the Black community is lower than what it was before Fair Housing Act. That's an indicator that not doing something is not the same as intentionally doing something. We also encounter divisiveness through using different types of labels around the work that we are talking about. And we also encounter, everybody know what NIMBYism is, not in my backyard. And so today we use rationales such as, I don't want multifamily housing because it increases traffic or it will overcrowd my schools. I will tell you, 40% of renters in Johnson County are cost burdened in their housing, meaning they're spending more than 30% of their income on their housing. And about 1 in 5 homeowners are cost burdened in their housing. If you're not turning over that housing and re-greening your schools, you won't have schools. They'll close or they'll consolidate. That's just an important, and I think there's assumptions that perpetuate regarding aspects of community members that we use the term of, I don't want this because my communities will be less safe. So now we're branding renters are less safe than homeowners. Lower income is less safe than higher income. Those are the types of things that, and I feel like it's a cycle. We go from unaware on an issue to aware, and I'm uncomfortable with being aware, and I'm not ready to be intentional, so I want to go back to unaware. I see that when we want to ban books. I think sometimes that's a movement to I want to be unaware. I don't want certain types of topics to be talked about in the workplace or in my schools or in community. I think that's that discomfort of going from unaware to aware and not knowing what to do with it and not ready to be intentional. And it's a strive to go back to being unaware. But what we are doing is we're bringing community together. And we're working with the health department, and we're working with the Health Forward Foundation. And that's how we had not only the housing study, but over 100 residents be a part of the housing task force to create the toolkit. And we're doing pilots with multiple cities around racial equity and being intentional.
Let's just go right down the line from Kiana, Megan, and Alex and talk about what people can do, what individuals can do to advance health equity in their community.
Civically engage. That's another regional investment that Health Forward is making to increase civic participation in all areas, but particularly the areas that impact health the most. And so, as I spoke of earlier, in terms of what you can do, right, and what your personal power and duty is to really take the time to understand what policies are in front of you, whether it be at federal, state, and local levels. Do your homework.
I would second the civic engagement, and I would say think about the things governments can do. They can build sidewalks. They can zone differently. They can just as systematically include people as much as they systematically exclude people. But I also think you as a resident can engage with your neighbors, engage with your community, talk to your neighbors about voting, about this kind of education. I mean, I think there's just a whole lot of ignorance. I want to go back to being unaware. And so I think it's incumbent upon all of us, once we know better, to do better.
I think in a similar vein, I just go one step even more reduced is just be willing to have uncomfortable conversations. I mean, you're all here, so you probably know that this is a problem already. You need to be active and engage yourself, but for a lot of people that comes with really difficult territory that they don't want to admit exists. And so I think living in that space and being more comfortable in that space is vitally important to actually achieve results.
I want to thank the panelists for their time tonight and for this really great conversation, diving into a bunch of different topics related back to this system of disinvestment and how that is playing out still in landscapes in different ways across this metro region. But it's also important to remember it's not just this metro region, right? There's similar stories to this. We could be having this panel in any city of any size across the United States and have a very similar conversation. So I appreciate your attention tonight, and I appreciate you all being involved. So thank you all so much.